Dear SAGES 2020 attendees, my name is Pouya Iranmanesh. I'm a minimally invasive surgery fellow at McMaster University in Ontario, Canada. It's a great pleasure and honor for me to present during this Bariatric Abstracts virtual session our study entitled Comparison of Single versus Double Anastomosis Duodenal Switch, a Single Center Experience. I have no disclosures. Biliopancreatic diversion with duodenal switch, BPDDS, also known as double anastomosis duodenal switch, or DADS, is currently established as one of the most efficient treatments for morbid obesity and its related comorbidities. Despite its excellent outcomes in terms of weight loss and comorbidity resolution, DADS represent less than 1% of the bariatric procedures performed in the US. Various reasons can explain this low percentage. There is the technical difficulty of the procedure, the increased postoperative morbidity, the risk of severe nutritional deficiencies which require lifelong surveillance, gastrointestinal side effects such as steatorrhea or gas bloating, and also lack of exposure to or knowledge of the procedure. The single anastomosis duodenal switch, SADS, also known as SIPS, SADI, or Loop DS, has been described in 2007 by Sanchez Pernate et al. As an easier and less morbid option. The data comparing SADS versus DADS is, however, limited and consists mostly of retrospective series with short follow-up length. The objective of the present study was to perform a comparison of medium-term outcomes between SADS and DADS. We therefore designed a retrospective registry-based cohort study. The registry that was used was the Ontario Bariatric Registry, which collects the data of all patients who undergo bariatric procedures in accredited centers in the province of Ontario, Canada. The time frame was 2010 until 2019. The setting was St. Joseph's Healthcare in Hamilton, Ontario, which at the time of this study was the only accredited center in the province to perform duodenal switch procedures. The inclusion criteria were patients older than 18 years undergoing SADS or DADS. Patients were included regardless of whether their surgery was performed as a one or planned two-stage procedure. Exclusion criteria were revisional bariatric surgery and refusal or inability to give informed consent. Our surgical technique was as follows. A 40 French bougie was used to perform the sleeve gastrectomy. For DADS procedures, the common channel length was 100 centimeters. The ruling was 150 centimeters. For SADS procedures, the total alimentary channel length was 250 centimeters. The duodenal ileostomy was performed either fully hand-sewn or with the help of a stapler with hand-sewn enterotomy closure. Our primary outcome was weight loss at 1 and 2 years after surgery. Secondary outcomes were postoperative complications, 30-day readmissions, operative time, and length of hospital stay. On this flowchart of the study, you can see that the registry contained 18,430 surgical bariatric patients at the time we retrieved the data. Among these, 107 patients underwent a duodenal switch procedure, including 82 patients who underwent a DADS and 25 patients who underwent SADS. The baseline characteristics were similar between groups, with the exception of a significantly higher BMI in the DADS group, with a difference of 4 BMI points, 59 versus 55. The 1-year follow-up rates for DADS was 55% and 56% for SADS. The 2-year follow-ups were slightly lower, with 45% for DADS and 40% for SADS. For the primary outcome, as you can see on this slide, there was no difference between groups in terms of percentage of excess weight loss and percentage of total body weight loss at 1 and 2 years after surgery. For the secondary outcomes, both groups had similar postoperative complication rates, including rates of severe postoperative complications, which were defined as a grade of 3 and above on the Dindo-Clavien classification. There was also no difference between groups in terms of 30-day readmissions, operative times, mean length of stay. For the medium-term outcomes, we're talking here about severe nutritional deficiencies and persistent diarrhea. There was a trend toward lower number of these complications in the SADS group, but these numbers were not statistically significant. Our study has several limitations. First, it is a retrospective study. It is also a registry-based study with all its related potential biases. We try to minimize these biases by manually checking every patient chart. The 2-year follow-up rates were relatively low, between 40 and 50%. We, however, know from multiple studies performed in the bariatric population that follow-up rates in this population are relatively suboptimal. Overall, we have small numbers, especially in the SADS group, and this might have biased our results as well. In conclusion, in our center, SADS and DADS had similar outcomes in terms of weight loss at 1 and 2 years after surgery. Secondary outcomes such as postoperative morbidity, length of stay, readmissions, and operative times were also similar between groups. Further, larger randomized studies with longer follow-up length are required to compare SADS and DADS and confirm these results. Thank you very much for your attention.